Got it. And then we will go to here. Screen 2. Hello, everybody, and welcome. We are going to start our presentation in just a few moments. I wanted to welcome everybody to this edition of the Bighearted Warrior Tour, a project of the Hypertrophic Cardiomyopathy Association. And today we are going to be hearing from our Center of Excellence team at Lahey Hospital Medical Center. And I'm going to just pop up the agenda, which we have a slight change in the agenda. Unfortunately, Barry Maron is unable to be here this evening, but we will be covering the content in other talks. So as we get started here tonight, I am going to launch a poll that you will have a few moments to answer if you are in the actual Zoom room with us. If you are not here in the Zoom room and you're watching live on Facebook, we will not be taking Q&A from Facebook, but either Stacy or Julie could go over there and drop the link so you can join us in the Zoom room as a webinar, and you can ask questions in the Zoom room as the program goes through the evening. We will be having a number of talks throughout the night. At the conclusion of each talk, we will answer a few questions. At the conclusion of all of the content on the agenda, we will open up for Q&A and discussion. And while we are doing Q&A and discussion, that will be recorded, that will be streamed on Facebook. At the conclusion of a few minutes of Q&A and we're wrapping up, we will stop streaming on Facebook. We will stop recording, and there will be a few moments at the end of the session in case you want to ask a question that will not be recorded. It'll just be the people that are in the room with us, and we can get going there. Tonight, we have a packed agenda, as we always do. You're going to hear a little bit of an update from the HCMA from yours truly. And then we're going to have an introduction of the program and the faculty from Dr. Maron. We're going to talk about sudden cardiac arrest prevention in HCM, atrial fibrillation management, and the treatment of surgical care for obstruction. And then you're going to hear a little bit about how to get in contact with the center. So I'm going to stop my screen share for a moment and introduce you to two of the HCMA team members who are here with us this evening. We have Stacy Titus, our Center of Excellence coordinator.
Good evening, everybody.
And Julie Russo, our volunteer coordinator.
Hi, everybody.
So for anybody wanting to volunteer, you get to hang out and talk to Julie and get involved with the organization that way. And we've got so many opportunities coming up for you to get involved. And Stacy helps us keep all of our Center of Excellence programming up and running. So Marty, I'm going to hand this over to you for some introductions of your team, and then I'll take it back.
Good. Thanks, Lisa. As always, great to be with you, patients. And we're looking forward to conveying some great information about HCM today and about our center at Lahey. Let me first start by introducing who we've got tonight. We've got co-director of the Lahey HCM Center, my friend and colleague, Ethan Rowin. He's going to be talking about atrial fibrillation. We've got Prem Shaker, chair of cardiothoracic surgery at Lahey. One of the main reasons that our program left Tufts to come to Lahey is Prem Shaker right there. You're going to hear from him about the surgical management of HCM in just a little bit. And we've got Katie Carroll, one of our three incredible nurse practitioners who without we would be lost, who will be talking a little bit about how to contact us and a little bit more in terms of details about the center at the end. And again, I apologize about my dad not being able to make it. My mom has a number of really significant medical issues at the moment, and he has to be available for her. And this was not the right time to be doing this for him for that reason. That said, it will have the opportunity for that reason to open it up for more questions, which are always really, I think, important for patients in terms of that. So that's the silver lining there. So we look forward to getting going.
Yep. Okay. So the Q&A is still open in terms of the poll, so we know where everybody's coming from, and we've pretty much got the country covered right now. So keep answering, and at the end of my talk, I will let our faculty know who's here and listening. As a housekeeping note, if you have questions during the presentation, you can use the Q&A box at the bottom of your Zoom screen. We will get to the questions after each talk. If there's too many questions after a particular talk, we'll hold them until the end and we'll address your questions at that time. So I'm going to give you guys a quick update on what's going on here at the HCMA. Lots happening right now. And I'm going to go back to screen share. We've already gone over our agenda, and I want to take a moment to thank our sponsors, Imbria, Tenaya Therapeutics, Bristol Myers Squibb, and Cytokinetics. They have been, most of them have been long-term sponsors of the Bighearted Warrior Tour, and we couldn't do programs like this without their support. So thank you very much for your support. Okay, next. HCM Awareness Day is coming, people. Everybody get ready. So we have new t-shirts this year that we put out, and we thank Otto, aka Tom Hanks, for giving HCM a little bit more of a public profile in his depiction of Otto Anderson, a gentleman who's a little bit grumpy and has hypertrophic cardiomyopathy. So we made t-shirts. We're not all grumpy like Otto, and nice little awareness message there. And those t-shirts are available online right now if you'd like to buy one and wear one for HCM Awareness Day. So HCM Awareness Day is the 4th Wednesday of February, and that is our day going forward. We used it last year, and this year it falls on the 22nd. So there's lots of 2s there this year, 2, 2, 2, 2, 3. We will be having a full day of programming from 11:30 in the morning Eastern time to about 3 in the afternoon. And then we will break, and then we will have an evening session. The full curriculum will be available online in the next couple of days, but we do encourage you to join us throughout the day. During the daytime session, we're going to be doing a legislative briefing on the HCM Act. I'll talk about that in just a moment tonight. And then we're going to hear from our centers and partners and a couple of other little tidbits throughout the day. And in the evening, we're going to have a really robust agenda. We're going to be meeting with some individual patients and watching their patient story unfold, and meeting with their physicians and hearing how they made some decisions for themselves. We're going to be talking about the HCM Act. We're going to be launching a new program called HCM Nest, which is a better way for us to communicate, and a little bit of explanation on how we're going to help solve some of the problems that our families face in terms of burden of disease and understanding what it's really like to live with HCM. So lots more than that going to be on the schedule, but stay tuned and come join us on that day. You can register on the website. So I want to do a little bit of a shout out. We have had some legislation passed and some resolutions passed in the past couple of weeks. The state of Ohio by law now recognizes HCM Awareness Day. Texas has a resolution, New Jersey has a law, Connecticut has a resolution, and Utah, we're close to the finish line on that as a resolution for HCM Awareness Day. And Massachusetts, we're in the hopper there. So thank you, Ethan. You've helped us out with that one, and hopefully we'll hear back from them soon. We will be doing a lot of work over the next year to, number one, get HCM Awareness Day on everybody's calendar statewide, as well as some other initiatives. Last week, the HCMA rented a movie theater in Morristown, New Jersey. I never thought I'd say that out loud, but we rented a movie theater and we did a group screening of A Man Called Otto, and then we had a little discussion. It went so well, we're going to California at the end of the month. Right after HCM Awareness Day, we're looking at the 24th potentially in the South San Francisco area, and we will do another screening of the movie at that time. Stay tuned for more details. I'm still getting the contract set up on that one. If you have not seen the movie yet, go see my social media feed on that. I think it's an important opportunity to talk about HCM in a different way and show it from a different perspective. No, it's not an in-depth discussion on his management strategies and what Tessie had done and how he had it done, but it's just life with HCM, and it's just a great movie, even if HCM wasn't part of it. So if you haven't seen it yet, please go do so. So one of the major initiatives for the HCMA in 2023 is moving forward with our Healthy Cardiac Monitoring Act. If you would like to get involved with state-based legislation to ensure that those who are undiagnosed have an opportunity to get in front of a cardiologist, that's exactly what the HCM Act does. So it is looking at your family heart health history and asking the same questions that we ask of student athletes in the well child examination instead of waiting for them to participate in athletics. It also provides for medical education to the providers doing those screening physicals. It is a sustainable, reproducible, and cost-effective method to get families identified with genetic and acquired heart disease as well and get them to the right healthcare providers. We will be distributing sign-on letters through our UJoin system where you can just put your name on a letter and send it on out to your state elected officials to let them know that you want this to be part of the law in your state. Currently, only the state of New Jersey includes cardiac components in the well child examination, and we need to put this around the country so that we can identify families who are at risk. This is just the basics of what the program is. It's ages 1 to 19, well child examination, professional development. It also adds some language to improve student participation physicals to make sure that they're homogenized throughout the state and that you don't have differences in different parts of states, which can happen. You can have home rule in terms of what questions get asked. So we want to homogenize that like we've done in the state of New Jersey, where there's only one form for student athletes. If we can identify these families in time, we not only get the child to the doctor, but we get the entire family evaluated by the appropriate level of healthcare professional. And this does not just look for hypertrophic cardiomyopathy. We're looking for all genetic heart diseases, whether they be structural or channelopathies, as well as congenital defects. So we hope you'll get involved with us on that project. Last year, I should say, the HCMA spent an awful lot of time updating our database. Over the past 27 years, I've had the opportunity to meet with thousands of families from all over the world. And I kind of would take notes on our conversation. So the next time you called back, we would know where you were coming from. Well, we're formalizing that into a formal registry for patients. And you're going to be able to engage with us through the NEST system that I'm going to be unfolding on the 22nd on HCM Awareness Day. And you'll learn how you can get more interactively involved with that, participate in Q&A, survey responses. There's going to be a lot of different mechanisms for you to share your HCM experience with the purpose of trying to help people raise their understanding of what HCM is and where the unmet needs are for our community. And we know that this is going to help us with some insights. And I'm going to give you a sneak peek of one of the things that we have found since January 1 to now. We started asking our questions just a little bit differently. And I'm going to get a little bit technical here. So if you're new to us, I apologize that this might get a little techie, but it'll make sense. When you go to a physician and they ask you how you're feeling, there is a scale that is used by your physicians called the New York Heart Association class score. And a 1 means you're pretty much doing well. A 2 is mildly symptomatic. 3 is more symptomatic. 4 is the most symptomatic. But we know with HCM, we have good days and we have bad days and we have average days. So when we're looking to see how well we're doing overall, it can be a little bit confusing because our numbers bounce around. So we started asking our questions about January 1 in that manner. What is a good day? What is a bad day? What is an average day? And we found something very interesting. And that is this slide here. It's a little bit noisy, but this is 37 consecutive individuals contacting the HCMA. And here we found that only 5 of you were consistently in one of the New York Heart Association classes. Patient 1 here was always a 2 on a good day, a bad day, and an average day. Patient 16 is always a 1, as is 22, but number 28 is always at a 3, and 30 is always at a 2, but the rest of them bounce around. And that's really difficult for clinical trial evaluation because we do bounce around a lot. So we want to help develop clinical trials that actually meet our needs and understand our community. And our patient registry is a unique way of collecting information, and we can use it to hopefully help improve clinical trial endpoints in the future. This is just one example of how we can use that information and data. So we're excited about building that out forward. I want to acknowledge that we are not only in Heart Month, but it is Black History Month. And as part of our efforts here at the HCMA, we know that there are some unmet needs within the Black community that we need to start addressing. So right now, out of all the centers in the country, we know 90% or roughly thereof of the patients that are being seen in HCMA recognized centers of excellence are Caucasian. So we know we're missing some individuals out there, and we need to find ways to engage them into good cardiac care. So why is this critically important? Because our country is changing. And this is a graph that indicates what the population of the US is today by racial breakdown and where we're going in the future. And if you look over here, this 50% mark, this beige line indicates the Caucasian community, which will cease to be the majority by 2045. So we must make sure that we're finding methods to get people who are not Caucasian into HCM Center of Excellence care to ensure that they have the best quality of care and outcomes. So what we are doing, we're putting out some grants right now for something called the All Hearts Collaborative. We're working in partnership with community leaders in Black and Brown communities and other healthcare professionals to ensure that we can bring healthcare screening into the community and help engage those individuals in HCM level of care outside of their communities, but still with a connection to the community. So this will all be part of our Health Equity Committee. And I just want to take a moment and acknowledge that it was inspired by a young man named Derek Armstead. Derek was a warrior with HCM, undiagnosed. We lost him in August of 2020. And here is a picture of him with his little son, just a couple of days before he passed away from undiagnosed HCM. So we want to have less stories like his, and we want to have more success stories of those of you with HCM living and thriving. So we're hoping that you can all get on board with our All Hearts Collaborative and make sure that we diagnose all with HCM. The HCMA is working on some new initiatives. This is a very quick slide. We have some projects that we're out for funding right now to use AI technology to help identify more individuals with HCM. This is actually a partnership we're working on with the Lahey team. We're working with many different partners in the community, organizations that we've worked with before and some new ones to us. So you're going to start hearing some new names. We have a new PR firm effective the first of the year, Mecki Media Relations out of Chicago. So hopefully you'll be able to see a little bit more higher profile of HCM in your local media. We're trying to get some stories planted out there, and that's kind of tying into our Share Your Story program. So you'll be hearing some more about that on HCM Awareness Day as well. And we are also in Heart Month, where we have a warrior of the day every day on social media sharing those stories. If you are in an area of the country and you don't have immediate access in a drivable location to an HCMA recognized Center of Excellence, we hear you. And we know it's not always easy to get there. So last year we started the Lori Fund, named after my sister Lori. And these provide micro travel grants to individuals traveling to Center of Excellence care. We'll provide up to $600 of funding for you to go to a center, whether you need a plane ticket, a hotel room, gas money, or money for food on the road, whatever your needs are that are going to help you get to Center of Excellence level care, we will help get you there with this travel stipend. Excuse me, I have hiccups, with this travel stipend. You can get the application online, and we are more than happy to provide these services to you. There is some financial need requirements for these monies to be placed with you. So just fill out the form. We want to give the money away. We want to help you get there. So please don't be shy and please apply. And this is my big exciting news for tonight. We are issuing a challenge. Ladies and gentlemen, you are hereby being challenged. And this is a fun challenge for an important reason. We all watched about a month ago an NFL player go down on the field in a full cardiac arrest. Reason for his cardiac arrest appears to be commotion cordis, a chest blow, but that's his health information. And if he wants to share it, he will share it more specifically. But what we saw was something pretty amazing. We saw him go down, and we saw action immediately. And we had hands on him by a trainer in about 10 seconds. So they were assessing him, they were starting CPR, they were bringing the AED out, they were getting their plan out, and they were saving his life. If you look back in comparison, and I'm not going to show you this video today, but if you look back 33 years ago, Hank Gathers had a very similar public cardiac arrest. When Hank Gathers hit the ground in 1990, A bunch of people sat around him and held his hand as he took his last breath, and he died in front of everybody. Damar did not die. They responded. They had good CPR, AED placement, and they acted because they planned it. It was like a drill. They drilled for the emergency over and over and over again. Back in 2010, the HCMA created Drill Dr. Heart, and it is a plan for cardiac arrest emergency. We're expecting that you've already been CPR trained and AED trained. That's not what the drill is. It's putting all of those skills to use with the community that you happen to be with, whether it be a school, a team, a workplace, a congregation, a community center. Wherever people meet, you should know how to respond to a cardiac arrest, much like you know how to respond to a fire. You grab the fire extinguisher, you take action. It's the same level of intensity when there's a cardiac arrest in process. So we are issuing our updated Drill Dr. Heart Challenge in a social media way. You can go online, go to my next screen, and take the challenge. You can learn how to do the drill. We have a full script for you so you can walk through with your team, your coworkers, your community center, your congregation, walk through the drill, understand what the laws are in your state related to AED and CPR participation, whether you can do it without training or not, and whether you're covered by Good Samaritan coverage or not for liability. You have those discussions, you practice it, you think about things like, where is the closest door to this room? Or is that door locked during the day because we're in a school and it's locked and I'm going to have to go open that in the event that I have to let EMS in the building from that location? Is there an AED on site in the building, or does EMS need to bring it? You can talk out all of these issues, and then you practice it by assigning everybody a task and walk through it a few times. So here's where the challenge comes in. Then we want you to film it, and we want you to post it to social media. It becomes passive education. People learn from watching you, and they vote for you. And if they vote for you and you get the most votes in your category, you can win an AED. Thank you to FibTech and our buddy Michael Papali, who is bringing this together with us, and Atlantic Healthcare, who's donating one of the AEDs. So DFibTech's doing 3, Atlantic Health is doing 1. So each category will be given an AED to the highest liked and engaged piece. The event will start now. You can post them starting now, and they'll run through April 23rd. And then we will announce the winners and we will give you your AEDs. So please join our social media challenge and practice your drill, film your drill, post your drill, share your drill, and get as many people as you can to engage in your drill. So if you need any printed materials or educational materials for a community event, a health fair, putting out at your place of work, we have lots of information here that we can share with you. Just write to the office and we will provide you with some of that information. And we're now creating kids health care material. We've created a little cartoon character. We'll probably debut him on HCM Awareness Day. And we have stickers for the kids that we're producing so we can start getting families to talk about heart health history. So if you haven't heard, I do a little podcast every Friday morning. And once a month, somebody named Marty Maron comes and joins me, and we have some deep dive conversations on topics of interest for HCM. And in fact, we have a podcast this week, Marty, in case you forgot. So we'll be doing that Friday morning. So I also have a new podcast friend. His name is Joey Graham. He's an individual who lives in Indiana, and he's recently diagnosed, and he's a news anchor from Indiana. And he is going to be publicly going through his HCM journey with you via podcast. And he's really interesting and entertaining, and he's unpacking his own story, and he wants to do it in live time to help teach other people as well. So we've got lots of interesting participants in Tales from the Heart. So come on in and learn more about that. And that's all I have to say tonight, but this does not happen because I sit here at a desk all day and do things. We have an amazing team at the HCMA, and this is our staff and our board. And last year we had over 2,800 hours of volunteer time from all of our wonderful community members. It takes a village, and I'm loving that you're all in our village together. So thank you for everything that you guys have done all year. And I want to just thank our partners at our Centers of Excellence programs around the country, specifically tonight to the Lahey team for joining us, our staff, our board members, our volunteers, our donors, and of course to Brandy, my donor. This week marks 6 years since my heart transplant, and I'm really happy to be able to be healthy and here with you today. But that only happened because a family decided to allow their loved one to be a donor. So please remember to sign your organ donation cards. It's important. And with that, I hand it back to Martin Maron.
Great. Thank you. A lot of incredible things going on. Amazing. So thank you for that overview. I'm going to then shift for a second and talk now. There we go. All right. So you can see those slides?
Got it. Perfect.
Okay, good. So just talk a minute about the center at Lahey for HCM. And I'm going to do that first by introducing our team. And I want to say that some of these slides are a little repetitive. Katie Carroll, our nurse practitioner at the end, is going to have some similar slides. She's going to dive into a little bit of a different angle on some of this information about the center. But let me take the opportunity first to introduce people listening to our team. Myself, I introduced Ethan, Rowin, who's the co-director with me, my dad, who unfortunately, as I said, cannot be with us today. And then we've got three incredible advanced nurse practitioners, Paula Mooney, Noreen Dolan, and Katie Carroll. All three do an incredible job of helping us to take as good a care of patients as we possibly can. Without them, we would be nowhere near as great a program as I think we are in delivering the highest level of care to patients with this disease. So our three nurse practitioners, our three physicians make up the core team that evaluates and sees patients with HCM and provides management recommendations at Lahey. Together, we are talking about over 100 years of combined clinical experience and expertise in HCM with this team. And again, to really have a world-class center for this disease that delivers care across different disciplines, you've got to have kind of great practitioners in those different areas of cardiovascular medicine. And those include cardiac surgery. You're going to hear from Prem Shaker in just a little bit. Prem is a world-renowned cardiac surgeon who has over 20 years of experience in surgical myectomy. We are incredibly honored to have the opportunity to essentially partner with him, taking care of patients with this disease with our move from Tufts to Lahey. In addition, alcohol septal ablation and catheter-based treatments is led by Tom Pimani, Gautam Gade, and Arjun Majithi. And then EP, Bruce Hook, and Jonathan Silver are two cornerstone electrophysiologists. And we've got obviously a number of people involved in the imaging portion of this evaluation for patients. Let me talk just a second about Prem Shaker. As I just said, chair of surgery at Lahey. Prem's going to give you a little bit more about his background, but as I said, over at this point 5,000 heart surgeries performed with over 20 years of experience specifically with myectomy. As I said, we couldn't be more thrilled to have the opportunity to work with him together in a collaborative way in the surgical management of those patients that need myectomy. Here is Tom Pimante, Gautam, and Arjun, who make up, again, the core of our invasive catheterization treatment arm, alcohol ablation, occasionally other interventional procedures, coronary catheterizations, particularly before patients are going to cardiac surgery, often need that. It's required. This is the team that does it. They've been performing invasive therapies in cardiovascular disease combined for over many decades. Tom Pimani, sort of a legend in the Boston area in terms of his prowess as an operator in the catheterization lab, including a longstanding experience with alcohol septal ablation as well. Electrophysiology, as I mentioned, the chief of electrophysiology here at Lahey is Bruce Hook, and Jonathan Silver, his colleague, Mary Lee Matty is the nurse practitioner in EP. This team comes to the HCM Center several times a month to evaluate and provide management recommendations for those HCM patients that have electrophysiology management issues, including helping to take care of the many patients with ICD devices as well. We couldn't be more thrilled to be working with this team, incredibly great people and incredible experience, obviously, in the management of arrhythmias, not just in HCM, but in all cardiovascular diseases. Let me just mention for 1 second about where we are. And this is perhaps, what I would consider to be an incredible advantage and strength to the Lahey Center, in addition to, of course, the expertise in the disease from a physician and nurse practitioner standpoint, is the location, which is here in this map, showing you in the sort of the northern part of the Boston suburb. So it's not downtown, it's just outside. And that means that you're talking about from the middle of Boston, depending on what type of day it is, about 20 to 30 minutes to reach us at Lahey. Sits really conveniently off a major highway, Route 93 and 95. And really what that means is it provides access for patients easily from the west, the north, and the south without having to go downtown, which I think everybody listening can probably appreciate the complexities that are involved now with traveling into a lot of the major cities, particularly the Northeast, including Boston, which is complicated and also very tiring, and for many patients, very frustrating. So this provides an opportunity to access us without having to do that in a convenient, easy way. Here's where we are. We are in a building that is situated essentially within minutes walking from the main hospital, which I'll show you in a minute. And this structure is obviously, as you can see, new, contemporary. We are housed on the 3rd floor. We've got over 4,000 square feet dedicated space to HCM, which includes the 3 clinic areas where patients are seen and evaluated, including a patient family room, consult room, as well as echo and other cardiopulmonary exercise testing, as well as stress echo labs, are all within the HCM Center in this building. Parking is conveniently located in front of the building. It is free. Patients can walk into the building to see us in a civilized manner, which has been, something that patients have already raved about in terms of just ease of access to us. And again, as I said, it's minutes walking to the main campus. Here's just a floor plan of the HCM Center, as I talked about, just showing you the layout, which again includes a number of patient exam rooms, the echo and stress rooms, and a patient family consult room, which really is an enormous space for patients to discuss and engage with us about their treatment plan, and also provide really in-depth education about HCM in a kind of more welcoming environment. There's the main hospital for Lahey, where the procedures and other advanced testing like cardiac MRI are performed. But again, in the vast majority of instances, there will not be a need to go to the main hospital, rather just getting the testing with echo and stress testing and seeing us at the HCM Center that I just showed you. So Katie's going to show you this again, so you'll see it again, but I'll just show it at the beginning in case there's some people who have to leave early. This is kind of how to get a hold of us and contact us for appointments or questions through Sue Vertente, who's been our administrative coordinator and program coordinator for many years in HCM, came over with us from Tufts, does an incredible job of keeping the ship going in the right direction in terms of coordination of patient appointments and testing. And there's the phone number. We've got a dedicated email to reach us, again, for questions or appointments. And I'd like to just conclude, if I can, before shifting to some of the didactic talks. I just wanted to take the opportunity to show you kind of a video that we put together that really emphasizes, I think, what are the greatest strengths to our program at Lahey. If I can just share that right now with you. It's a 3.5-minute video. Here it is.
Hypertrophic cardiomyopathy occurs in about 1 in 500 individuals in the general population. That being said, the majority of patients with HCM go undiagnosed.
The muscle of the heart, predominantly the left lower chamber of the heart, what we call the left ventricle, has an increase in wall thickness. And that increase in wall thickness with the changes at the cellular level can put some patients at increased risk in some point in their lifetime for a number of different adverse outcomes.
There's a wide spectrum in hypertrophic cardiomyopathy, and we see patients who have very little symptoms to those who are highly symptomatic and need some type of intervention.
Lahey offers the spectrum of treatment for patients with hypertrophic cardiomyopathy. We're fortunate in terms of we have a world-class myectomy surgeon with Prem. We have excellent interventional cardiologists for alcohol septal ablation, and we have an amazing electrophysiology team for ICD care and for treatment of atrial fibrillation.
The way that we have structured the HCM Center at Lahey, at the core, you've got a group of world expert HCM cardiologists, myself, Dr. Ethan Rowin, and my father.
I've been focused on one disease for 50 years. Here at Lahey, we've had a primary role in changing what HCM is.
For some years, I'd had shortness of breath, extreme fatigue, profuse sweating, feeling faint with pretty moderate activity, sometimes even fainting. It seemed like I was taking one of each type of heart control medication, and it still wasn't having an effect. My cardiologist immediately referred me to the Lahey Hospital Medical Center for HCM treatment.
We spend a lot of time trying to understand for each individual patient what may be the biggest driver in terms of what's making them feel poorly so that we can be as effective as we can in directing therapy at improving that patient's outcome.
One of the most important programs that we've grown here has been the hypertrophic cardiomyopathy program, particularly on the surgical side. We can see the area of the thickened muscle, which bulges below the aortic valve. Working through that narrow confines of the aorta, we are able to reach that area of the thickened muscle and take out enough muscle to relieve the obstruction.
After trying medicinal approaches and alcohol ablation, we decided on going with a septal myectomy, which solved all my problems completely.
Within 2 to 4 weeks, they are dramatically better. They are no longer dizzy. They are able to walk increasing amounts of distance without being short of breath. Their life is transformed.
When I read people's anecdotal stories about HCM treatment, almost everybody had difficulty with the diagnosis because, again, there wasn't a specialty department. People also had to travel for treatment. And so I felt blessed that I neither had to travel for treatment and had world-class doctors right here.
In many ways, the Lahey Hospital Medical Center is really responsible for the research and knowledge behind treating HCM patients.
We're always changing. We're always 2 steps ahead. We're always trying to think of ways to improve patient care and patient management.
And when we apply that kind of expertise and experience to the disease, we can really provide patients a chance to really achieve what they want out of life while still living with HCM.
Well done.
Thank you. All right.
So
So
before we pivot over to Ethan, I wanted to just take a look at our poll. You have 1 second left to fill out the poll if you haven't done it already, just so you know who we're talking to as we go through some Q&A, and we do have a couple of questions before we pivot as well. So I'm going to end the poll right now, and 61% of you are coming to us from the Northeast. We have people from the Southeast, the Southwest, the Midwest, Western United States, but we're all US based tonight. 57% are patients, 21% are a patient a patient with also a family member diagnosed, and 7% have a family member living with HCM. 4% are medical providers, 7% are industry, and 1%, welcome, is just curious. So welcome, just curious. We like you here too. Of those who are here, 32% are diagnosed just within the past 2 years. So a lot of this is new to them. 61% are on medication. 36% have an ICD. 29% have had septal reduction therapy. 25% are experiencing atrial fibrillation, and 18% have lost a family member to HCM. 4% are transplant, and that's not me. So there's another transplant person here tonight. 46% have had genetic testing, and 7% have been advised to have septal reduction therapy and are weighing their options tonight. So 21% are evaluating treatment options right now, and 79% of them are not evaluating other treatment options at this point. So we have a mixed bag, if you will, here tonight from the people who've been diagnosed a while and some newer. So just to answer a couple of questions from Lauren that were directed to me, I guess, up front. What can we do to pass this in Massachusetts? We've already submitted a resolution. I think that's what you're talking about, for the state of Massachusetts to consider HCM Awareness Day. We're waiting for word back. If we have an opportunity for testimony at the State House, stay tuned to us on social media. We'll put a call out if we get that. We don't typically have a lot of notice. They give us a couple of days when they're going to do something like that. So it's a little hard to handle, and we have to show up when we show up. Do we have patients on our board? Almost all of the members of the HCMA board of directors are patients. Some of them happen to be doctor patients. And one position is retained for Center of Excellence representation, and that position is currently taken by Dr. Martin Maron. And the rest of them are either patients or family members of those with HCM or have lost somebody with HCM. So I've answered those live. Anonymous attendee, question for Marty and me. Educating new patients is so important, but what information is out there for patients who have been living with HCM a long time? What new treatments, what meds are out there being talked about? What resources do you recommend for those who've hit a plateau with their treatments? Thank you. I will answer first, then I'll hand it to Marty. We encourage those of you who've been diagnosed for a while, but might be new to the HCMA, to check in on our newly diagnosed or new to HCMA, just so you understand how we work and how our systems have changed over time, and then participate in things like Bighearted Warrior Tour, and stay in touch with our newsletter and our website and our social feeds. That's where we're pumping out where there is new information coming out and where we're changing and where things are evolving. The good news is nothing stays static in HCM. The bad news is nothing stays static in HCM. We continually evolve. So if you think you've plateaued on your therapies and your treatment, we encourage you to meet with a high volume center who knows what trials are available and what else is going on out there. So Marty, I'll hand that question off to you. How should patients get engaged?
Well, I think you get engaged by, Center of Excellence, and also through, the HCMA organization. I mean, those are two great ways to be engaged. And so through both of those, you can really, as a patient, much better understand what other potential options therapeutically, could be available to you if you've hit, I think, as the patient said, a plateau with how they're feeling or doing, including, as you just mentioned, perhaps most importantly, the opportunity to engage in a clinical trial. There are, as we'll talk about, many opportunities with new therapies for both obstructive and non-obstructive that are being investigated that may help improve how patients feel if they, in fact, have hit a plateau. I don't know that's the case, and obviously in the case we're talking about specifically, but in general, that's those are really important, I think, points to consider.
Absolutely. Thank you. And next up, I believe we have Ethan Rowin.
I think actually I was going to do sudden death first, right?
Oh, you
Ethan?
could, oh, I'm sorry, my bad. Go
Right.
do sudden death now.
So let me do sudden
Let's
death.
not do sudden death.
Yeah, well, yeah, let's talk about prevention of sudden death, actually.
Good answer. Sorry, tried to jump the topic there a little bit.
All right, so let me do that, and then we'll shift it over to Ethan. So let me start here by sort of summarizing, what are the major principles of HCM? Most common genetic cardiovascular disease in the world, 1 in 500, maybe as common as 1 in 200 people anywhere in the world. Most common cause of sudden death in young patients, as well as competitive athletes. And of course, an important cause of disability for heart failure and atrial fibrillation for patients of any age. And so for the audience, I think it's maybe helpful to, in a way, start with kind of just an historical slide. This is really the first description in the contemporary or modern era of hypertrophic cardiomyopathy. It came from a pathologist in London in the late 1950s, Donald Tier. And what it describes is this pathologist had assembled a number of young people who had died suddenly without any other explanation. And on autopsy, he observed that the heart was bigger or thicker than it should be compared to normal. At that moment, they had actually, or he had actually thought that that was a tumor of the heart that was responsible for why it was thicker than usual, and therefore was the reason for the sudden death in those young people. And so this is the beginning of sort of the first kind of modern description of HCM. And of course, that's what these patients had. They had hypertrophic cardiomyopathy. They didn't have a cardiac tumor. And this is really, in a way, the beginning of our first understanding that this disease can be associated with some increase in risk for arrhythmias that could cause sudden cardiac arrest. And so when we kind of take a step back for a minute, one of the perhaps most important principal points, of course, and this is how we usually start our visits off with patients, is to say that the vast majority of patients, the vast majority with this disease, have a natural history that's consistent with a kind of normal life expectancy, normal longevity. That said, there are, subgroups of patients that could be at risk for complications of their disease, including sudden death. And I think the major point is that as we, can appreciate with certain therapies, that this is a disease that's treatable today, including preventing sudden death by identifying those that are at the highest risk and recommending for them preventive treatment in the form of not drugs, but an implantable cardioverter defibrillator. So if we focus for a minute on sudden death, sometimes patients ask, well, why is it exactly that these hearts, these HCM hearts that I have, are putting me at risk for abnormal rhythms? It's a great question. And we believe that the answer to that probably lies in the fact that if you look at the HCM heart muscle, and you look at it under the microscope, it's very abnormal. So not only is it abnormal to the eye because it's thicker than it should be, but it's also abnormal from a histologic, what we call histologic, meaning at the cellular level. Upper left is showing you the heart cells in this disease are arranged in a very chaotic disarray pattern, as opposed to being arranged in a very nice alignment. They're all over the place in a chaotic pattern. Upper right is showing you the blood vessels that supply blood to the heart muscle in this disease are abnormal too. You can see the lumen here is very narrow, so you're not getting oftentimes enough blood supply to the heart muscle that it needs, particularly since it's a thicker muscle than normal. The bottom of the figure is just showing you that in blue in the bottom left, between these abnormal heart cells, there is scar tissue. And it's stained in the bottom left as blue, and then in the bottom right, that scar tissue is stained as red. So that's what we call fibrosis. So the combination of the cells being arranged in a chaotic pattern, the blood vessels not being normal, and there being scar tissue sets up what we call kind of an abnormal substrate. It's a nidus, so to speak, for triggering an abnormal electrical impulse. which can occur in a way in an unpredictable kind of fashion. But when it happens, it's very fast, that abnormal rhythm. Because it's so fast, and that abnormal rhythm is called ventricular tachyarrhythmia, VT or VF. That rhythm is very fast, doesn't give blood supply to the brain in a way that is sufficient. Patients can then lose consciousness. And if that rhythm doesn't stop on its own pretty quick, or someone doesn't shock them out of it, then that rhythm can become, if it continues, life-threatening. That is what's called a cardiac arrest, abnormal rhythm from ventricular arrhythmias causing compromise in this disease, originating from the fact that it's a very abnormal heart cellular structure. So the way we assess patients then for whether they're at an increased risk that's high for an abnormal life-threatening arrhythmia is the first thing we do is we assess them with a number of tests as part of their evaluation. So there's pertinent information that helps us to decide about risk, sudden death risk in the family, personal and family history. We'll talk about what those specifics are in a minute, the examination, and then of course the imaging with echocardiography, MRI, and also ambulatory monitoring. That's a device that's put on. It captures captures the patient's rhythm over a certain period of time that will tell us if an abnormal rhythm is occurring. And so this is the sort of that forms the basis of the testing and information that's acquired to apply to decision-making about risk for a patient. And the way that information then gets translated to make that decision is what are called risk factors or risk markers. So this is how we do it. On all patients that we see, particularly on all new patients that we see, we assess those patients' risk for sudden death by evaluating for the presence in that individual patient's profile of one or more of what we call major risk markers. And those include a family history of a first degree or close relative who's died suddenly from HCM, unexplained passing out called syncope, when there's multiple bouts of abnormal short bursts of rhythm from the bottom chamber on the monitor, the ambulatory monitor, when the thickness of the heart muscle is extreme, when there's the presence of an abnormal structure at the bottom of the heart called an aneurysm, when there's a lot of scarring that we can assess through the MRI, which is called late gadolinium enhancement or LG. That's the scar that we can see in vivo, alive in a patient with MRI. And when the heart pump function drops below, way below what it should, which is what's called an ejection fraction, that's also a risk factor. So essentially, through the testing that we do in patients, we can determine whether a patient has one or more of these major risk markers. Each of these risk markers are in fact risk markers because of studies that have been done that have shown that each one of these risk factors is associated with a potential increase in risk of a life-threatening rhythm. And so therefore, one or more of the major risk markers can be enough in an individual patient with HCM to consider that patient risk to be high enough in the future of a life-threatening rhythm that it would be reasonable in that situation to consider that patient to be protected from sudden death with the implantable cardioverter defibrillator, ICD. I just wanted to mention two of our newer risk markers. These are newer in the terms of the last 5 to 10 years. One is the unusual HCM group of patients that have the development of what I said were aneurysms, these thinning of the tip of the heart of the HCM heart, and that's represented in these small arrows pointing to the tip of the heart, what we call the apex. In the top three images, those kind of arrows are pointing to a small in panel A, a medium in panel B, and a big in panel C aneurysm, what we call apical aneurysm. And so that thinning at the apex, the aneurysm, is scar tissue. It forms for unclear reasons, but when it forms, the aneurysm, because it's a thin area, is associated with an increased risk of life-threatening rhythms. That's why it's a risk factor for sudden death in patients with HCM who have or develop an apical aneurysm. In addition, we have very powerful imaging techniques today, and one of those is MRI. One of the strengths of MRI that make it unique, it gives us information that cannot be obtained with the echo. And that's the opportunity to look inside the muscle in a way at the presence and amount of scar tissue that we talked about before, using the injection of an intravenous contrast called gadolinium, which then is deposited in the heart muscle in areas of scarring that then can be visualized as very bright areas that we call late gadolinium enhancement, or LGE. That just equates to scar. And those arrows here are just pointing to MRI images of patients with HCM, and those very bright areas are in fact the areas of scarring. And when there's a lot of scarring in the heart in HCM, it increases the risk for life-threatening rhythms, and that is why this is a risk factor. We also have anti-risk factors, and that includes, age. Age is really important when we're talking about risk of sudden death, because as patients get older, actually, paradoxically, risk of sudden death decreases. And here's a study we did a long time ago showing you that when you achieve more advanced ages with HCM, 60 years or so, roughly, or beyond, risk of life-threatening rhythms, very low, even if you have one or more of those markers that I showed you before. So what that means is that if you're an older HCM patient, generally our threshold to put in an ICD is much higher than younger or middle-aged patients, because the risk of a life-threatening rhythm when you achieve advanced age with this disease is so low. And I just wanted to show, this is just a slide to show you that those risk markers that I showed you, we looked at how effective they were in our series, in our HCM center, over 17 years, over 2,000 patients with HCM. And the only point I want to make is just that those markers that I showed you, those risk markers, work very, very well at identifying those patients that are at the highest risk. Okay. And here is an example of that. When we use those risk markers to make decisions about who should get an ICD, in 82 of those patients, those devices that were implanted because of one or more of those risk markers ultimately delivered a life-saving shock to those 82 patients. It's not a perfect strategy, but it's very good. On the right is showing you over that period of time, we did have 5 patients that died suddenly, although 2 had risk markers but had declined the ICD, and 3 others had died suddenly without any of the risk factors. And I just wanted to show sort of the strength of this strategy and kind of how it can be so effective at just in an individual patient example. And so here's a 35-year-old who came to clinical attention because his brother died suddenly from HCM, and he was then evaluated, found to have HCM. And because of that fact, his brother died suddenly, and that's one of the risk factors for sudden death, he ultimately was recommended to have an ICD implanted to protect him potentially from a life-threatening rhythm. And so that was done at age 35 or age 36. And then several years went by, device was implanted again, nothing had happened. There was no therapies delivered. And then at age 41 in his sleep, this is what happened to the right. This is the ICD tracing, just showing that as this patient was sleeping, he went into ventricular tachycardia, fast bottom chamber life-threatening rhythm that then ultimately deteriorated into ventricular fibrillation. And ultimately at that point, the device in the bottom panel D shocks him in the middle of the night for what would have been a rhythm that would have, ultimately resulted in death, and shocked him back to a normal, regular rhythm, saving his life. 9 years go by after that, nothing happened. And then at age 50, another appropriate life-saving shock. This was all because the device was put in because he had one of those major risk factors, which in this case was the family history. And I'll just say that those risk markers and the ICD applied to this disease has really made a huge difference in decreasing the sudden death rates over time. Many patients have benefited from this strategy by their lives being saved because of the ICD. Here's some evidence to suggest that that's true. Here's the sudden death event rates for HCM in the 1980s to 2000s. And if you compare that to the contemporary 2020 era, the sudden death event rates in HCM have basically been cut in half because of our mature risk stratification strategy and the effectiveness of the ICD to abort those life-threatening rhythms. And then I'll conclude with that, and I'll sort of transition then over at this point to introducing Ethan Rowin, who will be talking about atrial fibrillation and HCM. Thank you.
Just pause here for a quick second. If anybody has any questions related to this presentation, now would be a good time to post them. The questions are not on target. We will be addressing those at the end of the session tonight. So if you have any questions about sudden cardiac arrest risk stratification, please post them now. I do have a question that came from the community earlier this week, and it was a term that I've not really thought about too much. How does the presence of slow ventricular tachycardia impact risk assessment for sudden cardiac arrest?
Yeah, so I think the answer is that we generally, and again, the way we usually see ventricular tachycardia is using the monitor. So these are usually results coming from an ambulatory monitor that the patient has worn. What we know is that we put a greater amount of weight or importance on non-sustained ventricular tachycardia when it's particularly fast, for example, or when there's runs of ventricular tachycardia that are long, or particularly high burden of them, okay, versus non-sustained VT that's short or slow. That doesn't mean that short or slow means the patient's not at risk. It just means that we put greater emphasis and importance when it's faster rather than slower. But again, we have to sort of always individualize. It depends again on the individual circumstances. But that's the answer to what the difference between those two means clinically.
And then I want to go into a slightly different definition of risk, that we can identify those who are high risk, but low risk doesn't mean no risk. Is that correct?
That's right. We never say no. We never say in HCM that a patient is at zero risk or no risk. You know, we always talk in terms of, you know, relative increases in risk, high, you know, maybe in intermediate, medium versus low. We never say no because it's impossible to really do that.
Okay, just wanted to be clear there. No other questions? It's off to Ethan.
Great, thank you.
Thanks.
Okay. Hopefully everyone can see my screen. I'm going to be talking about atrial fibrillation and HCM, talking a little bit about treatment options and outcomes in the contemporary era. Some disclosures that aren't really so pertinent to the talk. So what is atrial fibrillation, otherwise called AFib or AF? It's an irregular heartbeat that causes the heart to function inefficiently. Often the heartbeat during this is at fast rates. So normally when the heart beats, the top chamber, the atrium, gets an electrical signal that causes the bottom chamber, the ventricle, to beat. And it's very organized so that the top chamber beats and then the bottom chamber beats. Top chamber, bottom chamber. Atrial fibrillation is when there's an abnormal impulse in the top chamber, the atrium, and that therefore the top chamber is no longer contracting, no longer beating in sync with the bottom chamber, and that causes the heart rate to be irregular. And because the top chamber is not squeezing blood into the bottom chamber, is now inefficient in function. So what can you feel when you're in atrial fibrillation? A lot of people will feel palpitations, feeling their heart racing and beating irregularly. Some people won't notice necessarily palpitations, but they'll all of a sudden have a rapid increase in their other symptoms that they can have. So acute worsening and fatigue, feeling more winded and short of breath with activity, or feeling lightheaded or dizzy. And then less commonly, about 20% of HCM patients will actually not feel atrial fibrillation and really not feel the arrhythmia. How is AFib diagnosed? Most commonly, you come in because you're feeling worse from a symptom perspective, and an EKG will show that you're in AFib. Some people, their AFib self-terminates, so it stops by itself. And in that scenario is one of the reasons that we send patients home with monitors or prescribe ambulatory monitors to look for atrial fibrillation and what the causes of those self-terminating symptomatic episodes. And then I think for the future, it's probably going to be a lot more with wearable technology like the smartwatch. And in the present state, I think it's important to realize that when we're diagnosing AFib, it's really from the rhythm strip. So where you put your finger on the watch to record a rhythm. That's very different than when you get a potential alert on the watch, which says you're in an irregular rhythm. That is not diagnostic for AFib. So if you ever get one of those alerts and you have a watch that has the ability to generate a rhythm strip, the next step is to generate that rhythm strip. And if it says AFib or concerned about those symptoms, should contact your cardiologist, and you can send him or her that rhythm strip as well to look to see if this is indeed atrial fibrillation. How common is AFib in hypertrophic cardiomyopathy? It's actually the most common sustained arrhythmia. About 20% of HCM patients will develop clinical AFib during their lifetime. The risk of AFib in HCM is about 4 to 6 times higher than in the general population when matched to age. As you get older, there's a higher risk for atrial fibrillation development. That's both true in the general population, but also with HCM. We rarely see AFib in pediatric patients, but can happen. And in middle-aged 30 to 50-year-olds, about 10 to 15% of patients will have atrial fibrillation. I think one of the keys in terms of if you do not have an HCM diagnosis and you have a new diagnosis of AFib at a younger age, that's one of the red flags in our mind about screening that individual for HCM, just because it's rare for otherwise younger individuals with a normal heart to develop AFib. So in patients with HCM who do not have atrial fibrillation, can we find people who are at higher risk of developing AFib in the future? And we developed in that regard a score to find people who are at higher risk for new onset atrial fibrillation. So hopefully diagnose it earlier and allow for earlier treatment. And that's based on looking at a calculator, looking at a number of different markers. One is the top chamber size, the left atrial size. The larger the size of the top chamber of the heart, the higher risk for atrial fibrillation. Older age, as I mentioned, but also younger age at HCM diagnosis. So basically, the longer you've been living with HCM, the higher risk for AFib development. And then if you have other symptoms while you're in normal rhythm, also higher risk for AFib development. And with that, we're able to find what an individual's risk of AFib is at 2 and 5 years. And this score really does work to identify patients. This is now externally validating that score on another subset of patients from Toronto. And the performance is that if your risk by that score is low, over 5 years, you're at very, very low risk of developing AFib. Only 2% of patients with a low risk score will develop AFib over 5 years. So a lot of reassurance in that scenario. But if risk is high, that's a scenario where 20% of those patients without AFib will develop AFib over a 5-year period. And in my opinion, that's really a scenario where we need to do more screening with more longer monitors to look for AFib development. Outside of those risk factors, which are all not modifiable, meaning age, size of the top chamber of the heart, we really have no control over that. There are also a number of risk factors for AFib development that we can impact. And that is weight. Obesity specific to HCM is associated with a 2-fold increased risk in AFib development. And then also obstructive sleep apnea, where if someone has obstructive sleep apnea that's untreated, higher risk for AFib development, but also higher risk for recurrent AFib episodes. So that's a scenario where if you have sleep apnea or if you snore, and you really want to get an evaluation with a sleep study for consideration for treatment with like a CPAP machine, for example. These other risk markers, such as high blood pressure, diabetes, hyperthyroidism, as well as heavy amounts of alcohol or tobacco use, not clearly as associated with AFib specific to HCM, but we know in the general population is associated with AFib, and therefore another scenario where we might want to modify lifestyle to try to prevent AFib and recurrent AFib episodes. So once someone has atrial fibrillation, what's the treatment focus on? And that's really two different things. One is blood clots, and then 2 is symptoms. So as I mentioned, the top chamber of the heart, the atrium in AFib is not contracting, so that blood will pool in the top chamber of the heart, and that can lead to blood clots. And if those blood clots move from the heart, that can lead to a stroke. And so once we see AFib, it's a scenario where we start talking about blood thinners to prevent stroke and embolic events. 2 is symptoms. As I mentioned, individuals with AFib can have a lot of symptoms from the arrhythmia. And we get someone back into a normal rhythm, they go back to having their baseline symptoms. And if we're looking at therapies, which we're going to talk about in a second, to control rhythm, that's called a rhythm control strategy, meaning we're trying to get someone back into normal rhythm and keep them out of AFib. Not all patients, though, need a rhythm control strategy. As I mentioned, about 20% of patients with HCM and AFib have no increase in symptoms in AFib. And those individuals might decide to remain in atrial fibrillation and rather control rate, make sure the heart rate is staying down while in AFib. And that's called a rate control strategy. And if the AFib continues, that's called development of permanent atrial fibrillation, meaning you're staying in AFib because you have no symptoms in AFib. So if someone is symptomatic, we now have a number of good treatment options to keep someone in normal rhythm to help control symptoms. One of those options are a class of medications called antiarrhythmic drugs. And this class of medications help control and prevent AFib development. Historically, that was limited to a drug called amiodarone. Amiodarone is a really potent medication, but it has potential problems with long-term use. Not talking about short-term use where it's very safe and can really help keep someone out of AFib, but talking about potential decades of use. It can cause problems with other organs in the body, including lung, thyroid. And that's a scenario where we actually want to avoid amiodarone in younger patients to avoid potentially decades of treatment with that drug. And in that regard, we have a number of different options, including a drug called sotalol, dofetilide, disopyramide. All of these have their own sets of issues which need close monitoring, but do not have the same type of long-term effects on other organs in the body. And therefore, these tend to be the first line if we're going to start a drug for rhythm control in someone with HCM. As I said, though, they have their own set of need for monitoring, and often, especially for sotalol or dofetilide, you need to be hospitalized to start these medications. Other options for trying to keep someone in normal rhythm are what we call ablation procedures. And there are two types of ablations, and these are procedures where we do work by burning electrical signals into the top chamber of the heart, the atrium, to try to prevent AFib from developing, trying to block that abnormal signal that causes atrial fibrillation. In patients who have symptomatic obstruction, and Dr. Shaker is going to talk to you about that in a few minutes when you're talking about myectomy operation. So in patients who are undergoing the myectomy operation and have AFib, opens the opportunity for a maze procedure to be done at the time of ablation. This is an extensive ablation in the top chambers of the heart and can be really effective in decreasing AFib. About 70% of patients who have a maze procedure with myectomy for AFib do not have recurrent AFib at 3 years. So it can be really effective in preventing AFib recurrence and treats obstruction. That being said, it is a sternotomy. They have to open the chest, so it's a major operation. And it's really reserved for people who are otherwise undergoing the myectomy surgery. In contrast to that is a minimally invasive catheter-based procedure, all done through veins in the groin, and that's called the catheter AFib ablation. This can also help with AFib, but I think it's important to set appropriate expectations with this. In the general population, you'll often hear about AFib catheter ablations curing patients of AFib. And that expectation is unlikely to be the case in HCM, in that about 2/3 of HCM patients will have recurrent atrial fibrillation after an ablation. And therefore wouldn't consider it a cure, but that being said, it can substantially decrease atrial fibrillation episodes with this procedure. That being said, sometimes people need repeat procedures or need to be combined with an antiarrhythmic drug to control AFib, but nonetheless, with that combination can really control symptomatic AFib for over 90% of patients. Stroke risk, as we spoke about, is higher in HCM, and therefore individuals who have atrial fibrillation and HCM should be anticoagulated. And really anticoagulation should be considered to be started after the first episode. The anticoagulation is blood thinners. And so you always want to take into account risk of bleeding, which can worsen with these blood thinners, and weigh that versus risk of stroke. For most patients, when we're starting blood thinners, this is newer drugs. Historically, it has been Coumadin or warfarin, but now we frequently will use these newer drugs. You've probably seen commercials on TV for, like Eliquis, called apixaban, or Xarelto, rivaroxaban, or Pradaxa, dabigatran. All of these are very effective. And most patients overall prefer these drugs to Coumadin or warfarin, as they don't require as much monitoring, and diet doesn't affect these drugs. That being said, like everything, there are pros and cons to these drugs, as well as pros and cons to Coumadin. So always considering what the right choice is drug-wise for an individual. That being said, when HCM patients with AFib are started on these blood thinners, stroke risk is extraordinarily low long-term when you're on anticoagulation. So very effective at preventing strokes. That being said, we still have a number of unmet needs as it relates to AFib and HCM. First is that, as I said, anticoagulation is very good at preventing strokes when we know someone has atrial fibrillation. But unfortunately, in a subset of individuals, an embolic event is the first presenting symptom of atrial fibrillation. In fact, in the contemporary era, about 30% of all strokes in HCM patients occur at the time of the first sign of atrial fibrillation. And so we need better ways to detect AFib and HCM. And I think in large part that gets back to the potential for wearable devices in HCM. And then the second is that while we're talking about good treatment options for rhythm control and controlling symptoms, nonetheless, about 5 to 10% of HCM patients with atrial fibrillation will have a lot of recurrent AFib despite treatment, meaning that they are still having a lot of AFib despite multiple ablations, and they're failing other antiarrhythmic drugs and require amiodarone. And thereby, we still have work to do for sure in identifying HCM patients with AFib earlier and improving our treatment strategies. Nonetheless, I think it's important to take a step back and look at the improvements that we've made over really just the past 20 years for treating AFib and HCM. The pink is a cohort from Florence, Italy, and Minneapolis Heart when Barry was there from 2001. And the blue is 2017, our cohort of HCM patients with AFib. And you can see in 2001, almost 60% of HCM patients with AFib went on to have permanent AFib, meaning they were staying in AFib, as compared to only about 26% in our cohort. And the majority of our cohort, 90%, are essentially asymptomatic when in AFib, and that's the reason why they decided to move forward with staying in AFib. You can then look at how that reflects into how they feel as measured by what we call NYHA class, New York Heart Association class. But essentially, this is the proportion of patients who had severe symptoms when at the end of follow-up, and over 50% in 2001 of HCM patients with AFib had severe symptoms, as compared to just about 10% in contemporary treatment era. 1 in 5 HCM patients had embolic strokes in 2001. We're down to 6% in current era, and the majority of those, as I said, are patients as AFib as a stroke at the first presentation of AFib, or patients who are not on anticoagulation for variable reasons. And then perhaps most importantly, mortality risk with AFib was over 35% of patients died from HCM in 2001, in large part from complications of AFib, including advanced heart failure and stroke, down substantially by over tenfold in 2023 with contemporary treatment. So I think the takeaways when we're thinking about AFib and HCM, one is it's not necessarily inevitably progressive. We have good treatment options to control AFib, and that really results in low mortality. We have a very low threshold for anticoagulation to prevent strokes, and that anticoagulation is extraordinarily effective. By controlling rhythm, we can control symptoms and quality of life. So really think AFib is treatable in 2023, albeit often needs different treatments to get someone to have a good quality of life. Thank you.
You have lots of questions coming, Ethan. They've been populating. So we can have our faculty come on back because we may have some input from them as it relates to this particular topic. I will admit I was eating dinner while you were doing that. So thank you for the dinner education. Okay. So Barry and Ed, I'll get to your questions in the general session in just a little bit. So Ethan, can you please do some basic definition? What's the difference between AFib and a flutter?
So a flutter is a arrhythmia where there's a very clear circuit, meaning if AFib, the top chamber is moving around, is fluttering, and the source is all over the atrium. It's not one specific place. A flutter is when there's a specific place that's causing the arrhythmia to develop, normally on the right side of the heart under the tricuspid valve. So that's what a flutter is. There's an ablation procedure for a flutter, which is extraordinarily effective, even in HCM, to prevent a flutter from happening. I think one issue that causes confusion in HCM is when we talk about atypical flutter after an ablation. That scenario is really, in many ways, much more similar to AFib because the source from that is the prior ablation and is not necessarily as curable as a flutter is in the when it's not from an ablation.
Okay, that's a good answer. Second one came in from an alternative source. Because some people have my number and they text me things. So AFib ablation. Let's just talk about that for a minute. So we do one try. We get what, about 40% success. We try it a second time. You get a 40% success. You try it a third time. Half, 20. Those numbers sounding accurate. And then when do you give up?
Well, I think there's no right answer here. And part of that is that ablation strategy can be very variable. meaning that not all AFib ablations are the same. You can do an ablation in different parts of the top chamber of the heart. And so someone who has had 3 simple ablations, it might be worth trying a 4th. But someone who's had 3 very complex ablations, that might be a scenario where we might not want to try a 4th and try either amiodarone or an antiarrhythmic drug as opposed to repeating that.
Okay, that's very helpful. Thank you. Other questions? Nope, not going to do that one. So if you have a couple of short runs of a flutter, does that require anticoagulant?
So the answer is yes, with the difference for a flutter. If you had an a flutter ablation, it is for most patients curative, and therefore it's potentially reasonable to stop anticoagulation after a period of time if you have not had recurrent atrial flutter without prior atrial fibrillation. But stroke risk with a flutter is also increased, so should be on anticoagulation until you have a procedure to quote unquote cure a flutter.
Okay, this is kind of go EP line. So Marty, there's some device questions here too, but I'm going to crisscross them. Is there ever a role for somebody with HCM to just need a pacemaker? And at what frequency does that happen? Just pacing.
Yeah, I mean, there can be instances in which patients, will, for a number of different reasons, only need a pacemaker, which is a device to help a slow heart rate or slow heart rhythm that itself can sometimes be life-threatening or cause symptoms. And if they aren't at risk, for example, of a life-threatening sudden death arrhythmia, then occasionally we will recommend that they only have a pacemaker put in because they wouldn't like benefit from the ICD part of it. One example I'll give would be, for example, this came up this week where we had an older patient who underwent, for example, alcohol ablation, who had heart block as a result of the procedure, which is a known complication. And they had no evidence of increased risk for sudden death. They were of an older age, and the decision was made to put in a pacemaker, not an ICD. So that's an example.
Yeah, it's a really good example. I had somebody recently, or probably in the past year or so, making a similar decision for themselves. They had intermittent heart block, but they were in their late 80s and they were not interested in defibrillator therapy at that point, but they wanted to feel a little bit better day to day. So that's a very similar situation. Okay, so we answered those 2 live. Okay, it's not off topic, Doug, so I'm going to go at this. Can you briefly discuss the inevitable progression of an HCM patient with PVCs? So I'm saying here because it's kind of in the rhythm question, do increased PVCs are they any foretellers of future prognosis?
Yeah, well, I think this is, so I'll jump in because it's to do with ventricular rhythms, but essentially here's the answer. We don't have any evidence that there is a link or association between the burden of PVCs, single extra beats from the bottom chamber, PVCs, and an increased risk for sudden death. Okay. That said, again, I think you always have to sort of individualize these things, and there can always be, extreme circumstances where some patients could present with an enormous amount of PVCs, for example. That's incredibly rare, but it could be seen where, your judgment may be a little bit different there. But in general, PVCs are not associated with increased risk
Of sudden death. I'm going to take his question and tilt it a little bit because I think I know where he's coming from here. Do you see, as individuals become maybe more symptomatic and the disease appears to be progressing to more heart failure stages, do you see an increased PVC burden in those patients as compared to those who are more stable?
Not necessarily. I mean, not necessarily. No, it's not, they're not, that's not a one-to-one extrapolation. It could for an individual patient be true, but overall, that's not a general principle we see. No.
So PVCs, chill out, we're good.
Yeah, I mean, the principle there is PVCs, if they bother a patient, meaning they, patient's frustrated with how they make a patient feel, which can be, certainly true, particularly in HCM, then they're deserving of treatment. Otherwise, they don't have a lot of significance.
And going back up to Ethan's territory, what is a PAC? You're going to bounce between the ventricles, but you got to unmute yourself first.
PAC is a premature atrial contraction. Again, just like PVC doesn't have necessarily much clinical significance, except for in individual patients, they can be symptomatic and cause symptoms, but otherwise isn't a prognostic sign to the best of our knowledge.
Okay, going back to the ventricle, and then we're going to pivot over to Prem. Going back to the sudden cardiac arrest, you said SCD. I like to call it SCA because I'm being an optimist and that you're not going to die and that it's just an arrest. When you mention the increased risk due to a close family member passing, does that include second-degree relatives like uncles and aunts, or only first-degree relatives?
Yeah, it's a great question. In general, the greatest weight is placed on, that as a risk marker when it occurs in we're talking about close relatives. So that's usually first degree. That said, again, this is a theme, we've been talking about where nothing is completely, set in stone. So we have to apply, I should say, judgment sometimes. And in that setting, this is potentially one example of that where, we've seen families where there've been extensive sudden deaths in second degree or further relatives from HCM, where we have considered that to be enough that it is associated with a risk that's increased in that patient. So the bottom line is, we have to take a look at the whole picture, and distant beyond first degree sudden deaths could be impactful in making decisions about ICDs for individual patients.
Yeah, we see those complicated ones coming up all over the place. If it's 1 degree away, does it count? Does it not count? And it's also one of the reasons it's really important to know your family health history versus your family health myths, and asking family members what really happened to other family members and how they actually died and what and what was proven. It's really just an important message to all to document that family history well. Thanks for rephrasing the PVC question. You are very welcome, Doug. All right. Without further ado, we have our next speaker. Unless Prem has left the building. Up. Okay. Now we have Prem's slide starting, but we don't have Prem's camera or microphone on. There's the man.
All right, there you go. Well, let's do the other thing, which is that, and
Then you have to do the other thing.
is that good now?
There you go. 2 points to you. Thank you.
All right, I'm a quick learner. So Lisa, thank you to you and HCMA for inviting me today to speak. And thank you, Marty and Ethan, for the introduction earlier. You're very kind with your words. It's been a great pleasure having all of you here at the HCM Center at Lahey, and we have done tremendous amount of work in the last year, and enjoyed this very much. So I'm here to talk about surgery in HCM, and I will try to keep it short in the interest of time. So the history of surgery goes back to 1960, where a septal myotomy was described by Dr. Cleland. So this involved just an incision on the muscle. But the first version of septal myectomy was first described by Dr. Morrow in 1961. So it's an operation that goes way back in time, and along the way, as surgeons have refined these procedures to incorporate different things, and we'll talk about that in a minute. What do we know? We know that the first line of treatment for HCM is medical management, and a lot of people do well with medical management alone. But the second line is what I call invasive management, and that could be either surgery or alcohol septal ablation. As far as surgery is concerned, we see symptomatic patients who have either failed triple drug therapy or are intolerant to medical therapy, or in some occasions where even after the first line of drugs, it is deemed that their obstruction is so significant and also so easily amenable to surgery that they are offered surgery as the next option. And as always, we are, Ethan and Marty, very kind. We only see patients who are good surgical candidates. And our subset are patients who have a very focal obstruction in the left ventricular outflow tract. This LVOTO means left ventricular outflow tract, the path through which the blood leaves the heart. And that obstruction is caused by a combination of muscle overgrowth and an abnormal motion of the mitral valve. So the surgical options available for this classic variant of outflow tract obstruction is really centers around the first one, which I call septal myectomy plus. So the septal myectomy plus, basically the concept there is adequate reduction of the thickened muscle, which we call the fixed component, to the outflow tract obstruction. And that most of the time indirectly corrects the dynamic component, which is the systolic anterior motion of the mitral valve, which is the abnormal motion of the mitral valve. And that is the septal myectomy part, where just the resection of the fixed component muscle itself. I call it plus because we usually combine this with the release of some abnormal attachments inside the heart cavity itself. These could be either tiny little cords that are pulling the mitral valve in one direction or the other, or some abnormal muscle bundles that tend to distort the internal geometry of the left ventricle. So those things are released at the time of the myectomy procedure. So this is the standard operation that is done. The other two are, the second one, the RPR, is a more complex operation. There's a small group of surgeons that believe that we have to address multiple components in all patients, but a majority of surgeons just believe in the septal myectomy plus portion. All surgeries for HCM are done through a central incision in the front of the chest, what we call a midline sternotomy approach. And all patients need cardiopulmonary bypass or the heart-lung machine. And we need to stop your heart by using what is called cardioplegia. It's blood with high-dose potassium that protects the heart and stops it while we can expeditiously work on the heart to remove this excess muscle. Septal myectomy is done typically through the first approach, the transaortic approach. The second one I've just mentioned for completeness. So planning a septal myectomy, for the surgeons, we do it in conjunction with the HCM cardiologist, of course, and also with cardiac anesthesiologists who have specific expertise in the condition and its physiology. Almost all patients get a transthoracic echocardiogram, and occasionally some of them get a transesophageal echocardiogram. All patients nowadays get a cardiac MRI to look at muscle thickness and also to look at what we call fibrosis. Dr. Maron referred to this in his talk. And also in many instances, cardiac catheterization to measure the pressures inside the heart and also look at the arteries. So we aim to understand the complexity of the outflow tract obstruction because there are multiple components, like I said, the muscle, the valve, the abnormal attachments, etc. We need to know how thick the muscle is. We also need to understand the physiology and the function of the mitral valve, but also exclude some other things such as obstruction in other parts of the heart, which may not be treatable by surgery, and also exclude some other pathologies that may be independent of HCM. So the technical concepts, I mean, this is just language. I'll show you the pictures in a minute. And it is to create a trough of muscle resection. So there's a rectangular chunk of muscle that is resected or removed from this thickened area. And these are just the technical terminologies of where it starts and where it ends. But the second line is that it is the most important part of this operation is to remove as much obstructing muscle as is possible so that we can see all the way down to these papillary muscles. These are the muscles that help the mitral valve function. So when you look at it in pictures on the left here, this is the exposure that we see. We have actually opened the aorta, which is the main artery that comes out of the heart, and retracted these aortic valve leaflets apart. And inside, through that, we can see the thickened muscle. And this white band over here is the area where the valve has been hitting the muscle for whatever period of time. And then once we've identified this area, we take a sharp blade and we start by making two parallel cuts in the area where we want to take out the where we want to take out this rectangular trough of muscle. And then here we see the blade making a transverse cut connecting the two long cuts, and then very carefully we take out all the extra muscle that we can visualize and measure, and at the end we have an opening through which we can see down into the left ventricle or the main chamber of the heart. So that is really the standard septal myectomy procedure. And along with that, once the opening is nice and wide, we can look down through the opening to look for these abnormal muscle attachments and these abnormal cords, which we can release as well, and in addition to doing anything else that may be necessary. I mean, this is not to scare anybody, but it's a very technically precise operation. So therefore, it is important to get these operations done in centers of excellence, because there are many nuances to this operation that can make for an imperfect procedure, or you could have trouble. So first of all is if the amount of muscle resected is not enough, then you're left with incomplete procedure and incomplete resolution of symptoms because the gradients continue to exist. Additionally, if one is not very savvy with the procedure, you could damage adjacent structures like the aortic valve or the mitral valve, or create a hole in the muscle if you get too aggressive with muscle resection, called a ventricular septal defect, and of course produce conduction abnormalities called a heart block, which would then sign you up for a pacemaker with our friends on the electrophysiology service. So it's a very technically precise operation, so not to be taken lightly, and therefore we have centers of excellence. At the end of the during and at the end of the operation, the myectomies are assessed by two techniques. All patients get a TEE, and it's our practice here, mostly brought over by Dr. Maron and Dr. Rowin, the use of both pre and post-procedural gradient measurements using a drug called dobutamine to stimulate the heart to mimic exercise. And we measure the numbers before and after and demonstrate that the numbers have actually resolved in the right direction, which then will give us confidence that the patients will get the most benefit from the operation. And of course, we evaluate the mitral valve to make sure that the abnormal movement of the valve has gone away and that the valve doesn't leak as much. And of course, when is it an inadequate operation is when you've taken out less muscle or there is something going on with the valve that we previously did not understand correctly. So, what are the arguments in favor of getting this operation done as the invasive treatment? I mean, surgery, nobody wants to have surgery. The only people that want to be engaged in surgery are surgeons because that's what they do for a living. So, why is this condition best treated by surgery when it comes to invasive treatment? Is because it has been shown over time that it produces the most predictable result, and we can very accurately remove muscle in thickness, in length, and width, as we see, as directed by all the studies that we have done, the echo and the MRI. Surgery can address anything else that exists inside the heart. And if there's an issue with the mitral valve, we can fix that. If there is atrial fibrillation that, like Dr. Rowin alluded to earlier, we can do a maze procedure. If there are blockages in the arteries, we can do coronary surgery at the same time. So surgery offers not only a precise myectomy, but also the ability to deal with other cardiac issues concurrently. And as I said before, it is the one operation, but it is the invasive procedure that produces the most durable result. And today, it is a very low mortality and morbidity procedure. The likelihood that a patient will die from the operation, provided they don't have many other medical issues, the likelihood that you may die is less than 1%. And the likelihood of a major complication is also extraordinarily low. And most patients go from what we call a heart failure class 3 or class 4 to almost complete recovery, and their exercise tolerance comes back to class 1 levels. The only real issue with surgery is, compared to other heart operations, the need for a permanent pacemaker is a little higher for myectomies because we are in and around the electrical system of the heart, but it is not that high that it makes it prohibitively high. And indeed, it is actually lower than the risk of pacemaker with alcohol septal ablation. So then you flip the argument the other way and say, what is the argument against an alcohol septal ablation? And I say this because some years ago, alcohol ablation was fairly prevalent. And over time, we discovered that it was not that precise. It is not very precise because it is very much dependent on the location and size of these specific arteries called the septal perforator that we need to identify to put the alcohol into. And you put an alcohol into this artery, the artery dies, along with that the muscle dies as well, and that's how a controlled heart attack produces the effect needed. But if these arteries are not in the right spot, we can't control what it'll do when we close off this artery. So therefore, the thickness, the length, and the width of the heart attack or the infarct cannot be controlled. You sort of, do the procedure and sort of hope for the best. And of course, alcohol ablation does not offer any solutions to any mitral valve or other issues that the heart may have. There is a higher incidence of abnormal heart rhythms and also a higher incidence of ventricular septal defect or a hole in the muscle developing with alcohol septal ablation. And therefore, over the last decade plus, the pendulum has swung against alcohol septal ablation and towards surgery We still reserve alcohol septal ablations for patients who are either too scared to have surgery or are really not good candidates for surgery at all, or there is some other reason why an alcohol septal ablation should be considered. So finally, this is my last slide. Whenever we have a patient with obstructive HCM that comes to have septal myectomy, it actually takes a village to take this person from start to finish. And it all starts with the experienced HCM cardiologist like Dr. Maron Senior and Junior and Dr. Rowin and their advanced practice provider staff. It all starts there, and they eventually refer patients to us for surgical treatment. So you need to have experienced surgeons. It is very important to have trained cardiac anesthesiologists because the pathophysiology of obstructive HCM is very much different than what we see every day in heart surgery. So it is important for the anesthesiologist to know what exactly they are dealing with and how to evaluate. Fortunately for us, Dr. Rowin and Maron come to the operating room to help us with the echo both before and after. It is very important to have a trained operating room team. It is like I said, the surgery is so nuanced and so precise that the people working alongside you should know exactly what you need and what to do. And many of the times, one of the things that needs to be done is to stand absolutely still. Because anybody makes a false move, then the blade moves in the wrong direction. So the team working with me, my OR nurse and my APP staff have been doing this with me for 20 years. So, and that makes a lot of difference when you execute an operation as precise as this. Then after surgery, experienced intensivists that can take you through the recovery, again, understanding the physiology of the condition that is different from the guy next door who had a coronary bypass operation. We need very strong support from advanced practice providers and nurses. And of course, this is all backed up by expert imaging and other facilities that a hospital like Lahey can offer. And not to leave them out, but all of you will agree that this entire process also is facilitated by a core group of people inside our offices. Marty and Ethan mentioned Sue Vertente on their side, helps connect the patients with facilitate appointments, connect them with Marty and Ethan as required. And on my side, we have Brianna Drago. And it's very important. These individuals are our faces to you, and we really cannot do all that we do without this entire team working together. And it is really it is not an isolated phenomena. It is a joint effort by all of us. So I'll stop there and happy to take questions. Thank you for this opportunity. And
Thank you for your presentation. That was great. And we have some questions populating in right now. We still have kind of a potpourri going on at the moment. So I will encourage everybody to submit their surgery related questions now, and we'll get to answering those in just a moment. I just wanted to take a step back. I love the history of myectomy, maybe because the surgeon who created it had HCM himself. And it's always that great story of Maron getting diagnosed and creating the procedure before he even knew she had the disease. So I geek out on that story often. But looking at the myectomy that Maron created versus what is done today, is it a shadow of what it used to be because it's so much bigger? What did we learn about sectioning and removing tissue? Is it a trough or is it the whole band, or how do you look at where we've come?
Maron developed a standard, what we call a standard Maron operation, where it was a rectangular trough. That was it. And they didn't do anything more than that. But now with CMR and with TEE, we can actually map out, how much interventricular septal muscle needs to be taken out. And it is always more than that rectangular trough. And sometimes we move leftward, sometimes we move rightward underneath the mitral valve, and sometimes we have to go farther down, a procedure called extended septal myectomy, where we have to almost go to the level of the middle of the left ventricle or the chamber of the heart. So it's no longer a standard Maron operation. It moves to the left, it moves to the right, and it moves down, and it's all guided by echocardiography and MRI that tells us what needs to come out.
And the evolution of myectomy, I was thinking about this one the other day. When I first started the HCMA in the 90s, you wouldn't bring an imager into the OR with you. That was kind of something that happened much later. So some of these patients, we wouldn't know if they had a gradient or not that was recurring until a couple of days post-op, and they'd go back to the OR. Can you talk about the importance of having a skilled HCM expert right there with you versus, an anesthesiologist or somebody who doesn't really understand HCM anatomy as much doing an echo at that point?
Oh no, it is invaluable. I mean, there is. It's extraordinary that Marty and Ethan come to the OR and they do the echoes and give us precise measurements and give us the gradients, and so we know exactly. Again, most of the time we know this already, but it is always good to reconfirm the whole thing in the operating room before incision is made. But most importantly is what you just alluded to is after. Was the resection adequate? And most of the time under anesthesia, everything looks perfect. Sometimes, you're taking out muscle and it looks like it's all going to work fine. And then we do the stimulation with the dobutamine. We provoke the heart and we simulate exercise, and then we measure again. And those are the patients that you're talking about, Lisa, is that those are the ones that get missed out. And in the older days and in centers where they don't involve experts in the intraoperative evaluation, all of this comes out in the postoperative period, 48, 72 hours later, and then you're making a return trip back. So having the expertise right there at table side makes so much of a difference. And we can immediately say that this patient is going to do well based on the numbers we see.
So I have a very cute question here. I realize every patient is different, but how many years can most HCM patients expect a myectomy to last? She had one 6 years ago and she's currently 76 years old. How long does it last?
It should be, it should last a very, very long time. I hate to use the word forever because nothing is forever. But it lasts an extraordinarily long period of time because, there are some instances where I've been back inside an HCM patient for a second operation, not to take out more muscle, but sometimes to replace valves and things like that. And we find that it sort of scars down. Most of the time it scars down. So that area remains nice and flat and unobstructed for an extended period of time. I would say decade plus easily. Very rarely have I heard need for a repeat myectomy. When the first myectomy was actually fine, I mean, we've done repeat myectomies from other centers where the myectomy was inadequate, but most myectomies done well and correctly the first time are good for an very, very long period of time. I'm happy to hear Ethan's and Marty's experience on this as well.
Ethan, you want to chime in?
Yeah, I agree completely. For most patients, when it's done with an experienced surgeon, it really can be lifelong. The only exceptions are the very rare scenarios in younger patients, pediatric patients, when they haven't finished, quote unquote, growing, and you can have quote unquote recurrent obstruction, but otherwise really should be, from vast majority of patients, lifelong.
I've seen another phenomena occur, albeit incredibly rarely, that sometimes after the first myectomy, you give it a few years and the heart contracts slightly differently. And I've seen obstruction occur in a completely different region of the heart. Again, like maybe 4 or 5 times in 20 years. But I've seen the phenomena occur where you've got typical outflow tract obstruction and then you get some other point a little bit lower. Just by the way, I think the heart beats, the geometry changed. So it's hard when you're the 1 in a million one that does that, but I've seen it a couple times now. So it's probably can happen. You guys want to chime in on that when you change the geometry of the heart?
Actually, I have not encountered any of them on my, on my surgical practice, but I don't know what Ethan or Marty have seen, when they follow these patients in the long run.
I think as everyone understands here, it's such a heterogeneous disease. I mean, every patient is different, everyone's anatomy is different. And so when we're answering a lot of these questions, we're talking in general for the majority of patients, and there's always outliers for sure, and unique scenarios.
How long is the myectomy procedure itself, and how long does a patient stay in the hospital?
Most patients, a septal myectomy procedure with or without a mitral valve plication plus release, etc., is about a 4-hour operation. Skin incision to skin closure plus add an hour of anesthesia time, so 5 hours in the operating room. And most patients are in ICU for a day and a half, and in the hospital for a total of 4 to 5 days, unless there is a reason why they need to stay longer than that.
That's an amazingly short amount of time to have somebody's hands on your heart and then be back out on the street. But it's not, having had an open heart procedure, it's not actually as horrible as you might think. I've had abdominal surgery and chest surgery. I'd do the chest again. I wouldn't do the abdomen. So if you're thinking about how long is it going to take me to get up and moving again, when do you guys get your patients up and walking? 24 hours?
Yeah, 24 hours the following day. Yeah.
There's no laying around in beds after myectomies, people. You got to get up. You got to move. Right? Is that what we tell them?
100%.
Okay. All right. So we've got some other questions, but I think we'll hold those till the final session. And we're going to hear from Katie. And I think Ethan's going to share the slides. Yeah.
Hi, I'm Katie. I'm one of the nurse practitioners. As you've already seen, this is our hypertrophic cardiomyopathy group at Lahey. Dr. Maron and Dr. Barry Maron see patients on Tuesdays and Wednesdays. Dr. Ethan Rowin sees patients on Thursdays and Fridays. The nurse practitioners, Paula, Noreen, and myself alternate on days working with different physicians. So if you do come to see us, you will see one of the nurse practitioners along with the physician that you're scheduled to see. Ethan, next slide. So this is a picture of our new HCM center. Make note that we are at 67 West on 67 South Bedford Street. There's a east side of the building and a west side of the building. They look identical. If you enter on the east side, you can still get to the west side, but you'll have to walk a ways. So enter on the west side. Ethan, next slide. And as Marty already said, the best way to make an appointment with us is to contact Sue or Caitlin, who is our wonderful MA, at 1-825-8650, or to email us. In terms of making an appointment with us, I'd recommend calling registration first and getting a medical record number before you call and make an appointment, because you will need that for Sue or Caitlin to schedule your visit. Your insurance may also require a referral, so you may want to inquire with your insurance before making an appointment, because you may need to contact your primary care office to get that referral. I'd also recommend calling our office about a week or two before your scheduled appointment to make sure that we've received all of your medical records or any imaging that you had done prior to your visit with us. If you're not having an echo stress, or cardiac MRI at our center, it's really important that we have all of your outside imaging so that we can give you, the most comprehensive visit possible. And then also when you come in, bring a list of your medications, current medications, and then also any recent medications that you were tried on, if they didn't work, or if they worked, or whatever reason they were discontinued. And I will end there, since I know that we are going over, and we'll have more time for questions.
Always have questions. There's always questions. Okay. So now we're going to go into the potpourri side of questions and answers. We're going to go for a couple minutes here, and then we're going to stop streaming on Facebook and say bye-bye Facebook, and we're going to stop recording. But I will go back to the earliest questions. And this is one that I got a few of today. So we've heard about what you guys offer, and we've heard about surgery today. People are very interested to learn about myosin inhibitors. What is the take on myosin inhibitors, both in clinical practice and in trials? What's going on at Lahey with myosin inhibitors?
Ethan, you want to take that?
Sure. I'll let you talk about the clinical trials, and I'll talk about myosin inhibitors in general. So obviously really exciting times in HCM as it relates to new drug therapies. May of 2022, or end of April 2022, first drug specific with FDA approval for treatment of obstructive HCM, mavacamten, initially developed by Myocardia, bought by Bristol Myers Squibb. And really used for symptom improvement in patients with obstructive HCM. Again, really exciting that we have a new treatment. I think, like everything, it's really about individualizing that treatment for an individual patient, and making decision together in terms of, what the right treatment option is for them. I think it's really important to realize that new medication, mavacamten, does carry a risk of causing heart failure. And what we mean by that is the squeeze in HCM's heart is really forceful. It's hyperdynamic. So the heart really comes together, and that is in part mechanism for obstruction. The drug causes the squeeze of the heart to decrease, and by that it lowers the amount of obstruction. And whenever you lower obstruction, symptoms can improve. That being said, in 5 to 10% of cases, it will overshoot, meaning the heart function will get too weak. And that can obviously be dangerous if the heart is not functioning appropriately, and therefore it needs to be very, very closely monitored to make sure that if that happens, we stop the drug as soon as possible to try to prevent anything bad from happening. So it's a really challenging drug to monitor. It's a really a drug that needs a lot of monitoring. Symptom improvement can be good for some patients, but it's probably not as effective as surgery, which is a more definitive relief of outflow obstruction. Don't really know kind of long-term effects, which is obviously under study. And it would probably be a lifelong treatment. And so for younger individuals or patients who don't want to be on drugs, is probably not for the rest of their lives, probably not the right treatment strategy for them. And then obviously last is potential cost and making sure that it's approved by insurance, because in some cases out-of-pocket cost can be ridiculous and unacceptable.
That's a good way to put out-of-pocket costs on that one. It is a little expensive. So that's the one that's on market right now and has FDA approval. So that's Camzyos or mavacamten. Or do you want to talk about clinical trials in myosin inhibitors?
Yeah, absolutely. I'll just add one thing to what Ethan was saying, which, is that, I think the really important point here right now is that with mavacamten, it's one of the additional tools in the toolbox. We've talked about that before, and that's really helpful and that's really important. But patients really need to hear, when they're being considered for mavacamten, they also need to hear all the other treatment options, the pros and cons, the strengths and limitations of those, and really ultimately to be able to make an individualized decision for what that particular patient best option may be. It may be mavacamten, it may not be, because there may be other factors and considerations that weigh and sway the decision in a different direction for that individual patient. So essentially the message there is, I think all patients at this point who get to that crossroads where they're frustrated with how they feel with obstructive HCM, despite beta blocker or calcium channel blocker, really need to hear about additional drug therapies with negative inotropic agents, with disopyramide or norpace and mavacamten, and the invasive options like myectomy and alcohol ablation. So, and hopefully have that conversation at a center of excellence where, they can get the most important information, specific information about those options.
I'm going to pause you right there for just a quick sec.
Yep.
So I'm not going to surprise anybody with what I'm about to say here. I truly believe that assessment of your obstruction and your treatment options really, really needs to be at a center of excellence.
Right.
There are a lot of community physicians who took a course that took a few minutes online so that they could prescribe Camzyos and they could participate in what's called the REMS. Just because they took a few minute course online that they know how to safely administer the drugs as per the government's requirement for prescribing does not mean that they have a deep appreciation of hypertrophic cardiomyopathy as a disease state, and it is not a mainstay in their practice. So I would just like you guys to comment on why it's still really, really important to have a myosin inhibitor dosed at a high volume center who understands HCM and sees it very regularly.
That's right. That's right. And also part of that conversation could be about, clinical trials as well. That's another potential option here. In this space really means there's what we call next generations, the next version of myosin inhibitor called aficamten. The company that makes that's called Cytokinetics. It's currently still under investigation as a drug therapy for symptomatic obstructive HCM, has a similar action as mavacamten. It differs from mavacamten essentially in some of the what we call kind of pharmacodynamic properties. For example, aficamten's half-life is a little different than mavacamten. It has a different metabolism a little bit. It has different interactions with other drugs and so forth. And so those differences, we don't know whether or not those will translate into differences in safety or efficacy yet. That's what's being investigated right now in what is a phase 3 trial. And so some patients, that may be the right choice to be involved in a clinical trial like that, where they can gain access to the drug in a clinical trial environment, and then afterwards in an open label extension, potentially avoiding some cost issues with that. Obviously, they have to participate in the clinical trial to do that. So I think, again, as Ethan was saying, it's an exciting time. We've got, more options coming down the line. and those options, will be different potentially a little bit than mavacamten. We'll have to see what that amounts to or translates to in terms of actual differences in efficacy and safety.
So teasing a little bit on that one, you and I are both aware that there's some new companies with some new concepts that are kind of offshoots of what we've learned about myosin inhibitors. So I guess what I want to say is the train doesn't stop here. It's continuing and there's some new options coming. You want to talk a little bit about what the future might hold?
Well, I think what we're going to see is, as you were just saying, this is just the beginning, literally, I think, of drugs, for example, that modulate the sarcomere, the myosin, the structural apparatus of the heart. We're probably going to see, as we go forward, even different versions of that kind of class of drugs coming down the pike as well. We're seeing other drugs too applied to HCM, drugs that alter metabolism, energy utilization, that may be helpful alone or maybe even in combination with myosin inhibitors. That's another important concept, that we may be looking in the future at combination therapy to really get the optimal improvement in symptoms with new and existing drugs. And then, of course, perhaps farther down the timeline, but what is beginning are investigations looking at gene therapy techniques in this disease, potentially, again, altering the biological basis of HCM to potentially have important effects that again are under a lot of investigation and will be for quite some time. That's not something we're going to see probably anytime soon, but is just beginning.
So yes, the gene therapy is coming. We're going to be doing full sessions on that coming up. So stay tuned for more on that. That's like 2.5 hours in and of itself to dive into that. So for right now, what I'm going to do, I'm going to call this speed dating by questions, because we've got like 10 questions plus here. So I'm going to go through them really fast. Are you ready? On your marks, get set, HCM fast track. How much of a mitigating factor is being over 65 if somebody has, for sudden cardiac arrest risk, if somebody has a small apical aneurysm and 15% LGE? So we have scar and we have a small aneurysm and they're over 65. How does that mitigate?
Apical aneurysms is an interesting risk marker in that it's one of the few risk markers where risk seems to persist even in advanced stages. And so don't consider age to necessarily be a mitigating factor in that scenario.
Okay. When should an asymptomatic patient with HCM transition from a general cardiologist to a center, or any center, yours or others?
I'd first say that even though the patient may be asymptomatic, I still think there's a lot of value in visiting a center of excellence to at least get a initial evaluation at that level. There may be other considerations that were not part of that patient's prior evaluation that could be helpful. So I do think that that's a scenario where, that even though there are no significant symptoms at that moment, that it's still, again, important to at least have an initial evaluation at a center of excellence. And I think, of course, looking in the future that, anytime things start to change, that would be another potential opportunity to visit a center of excellence. That could be change in terms of how patients feel, or changes that a patient may hear are occurring on the echo or imaging or other testing. That's another, time to pursue additional input from a center.
I couldn't agree more. Check in early, even before maybe you think you need it, because if you're in a crisis and now you need people to get to know who you normally are, it's not a really good time to start to establish a relationship when you're not feeling at your best. So it's best to meet while things are calm, set a plan, know what to do if something goes a little awry, and when to contact and how to communicate, and open up those pathways. It's way easier that way than to kind of walk into Lahey while there's a whole bunch of stuff going on. And then you have to meet everybody and they have to meet you, and you have to figure out all the paperwork and you got to do all the nonsense stuff. Let's get that out of the way first. It works better. we have two back-to-back AFib questions. I'm going to ask them both together. Is ablation tried before arrhythmia, antiarrhythmics in AFib? And is ablation a treatment for ventricular arrhythmias? Hold that. And then a follow-up question for Ethan. Would you try amiodarone or disopyramide before you did an AFib ablation, or do you do it backwards, or can it go in either direction? Go.
So again, every patient is different, and every patient wants to try things in different orders, which is appropriate in terms of a drug versus a procedure. I think in general, our strategy tends to be an antiarrhythmic drug before ablation, but not amiodarone, just because of concern, again, over long-term risk of using amio. And then a second part of that question is, that being said, if someone has had an ablation and previously did not do well with an antiarrhythmic drug, they actually might do well after the ablation with that same antiarrhythmic drug. And so that's what I meant by, if you have an ablation and still having AFib, it might be worth retrying that antiarrhythmic because the ablation helps for efficacy. Second part of that was ventricular arrhythmias. Don't use antiarrhythmic drugs in replacement for ICD. They are not definitive. That being said, in the rare scenario where someone is having recurrent VT with ICD shocks, might consider using an antiarrhythmic drug to suppress ventricular tachycardia.
Okay. Can heart block be reversed?
So so here's the answer is that, yes, I mean, there can be situations where a patient can be in heart block for a certain period of time, and it's possible that they can come out of that and regain kind of more normal conduction. That's possible. Okay. And so that is one possible pathway. That's probably the least likely. More likely is that if someone has complete heart block, some of it depends a little bit on the reason, but most often if someone is or does go into complete heart block consistently, that it's less likely that they will go back into regular rhythm.
If somebody already has an ICD, is there any value to continuing to do MRIs?
Not usually, to be honest. I mean, there can be select situations that could come up where an MRI could potentially be really important in that patient. But for kind of most of the routine indications for MRI, cardiac MRI in HCM, those have sort of already been answered if the device is in. So it takes on much, much less importance.
Okay, Mark, we answered your question early in the session. Maybe you came in a little bit late. We went over the entire ICD risk stratification. This presentation will be available either for review tonight on Facebook, so you can go back to that first session, or it'll be available on YouTube and you'll get a very comprehensive answer there. It'll be on YouTube tomorrow. Okay. Why are HCM patients at higher risk for atrial arrhythmias?
Probably twofold. One is whenever the left ventricle is thick, like with HCM, there can be higher pressures in the top chamber, the atrium, and that atrium can get bigger, and that predisposes to atrial fibrillation. And then second is, I think there's a lot of thought that there's a primary issue with the atrium that predisposes HCM patients to AFib, what we call an atrial myopathy.
Okay, pausing for one moment. Like the earrings, they're made by an HCM community member, and she's doing a fundraiser for Heart Month, and you can use the link in the chat box, and you can buy earrings, and their proceeds will go to the HCMA from now until Valentine's Day. I almost forgot to give her that little prop there. Okay. Ooh, that's a good one, Joe, but I'm going to hold that one for last because I have a breaking announcement. There's breaking news tonight at the HCMA. Wearable devices. Mine might detect AFib. When is a good idea to wear wearable devices, Dr. Rowin? Didn't we just have this conversation?
So first, I think while I support wearable devices, I think there's still a lot of room to grow our knowledge on them. And there's also a lot of room for improvement in technology. One of the problems is a lot of the battery lives on the watches are minimal. For example, the Apple Watch is a less than 24-hour battery life most of the time. So not possible to always wear it, for sure.
Okay. I like Richard's question here. We're going to get a little detailed. And I'm going to start his question by saying, I can't address you specifically, Richard. We're going to talk about this in a general state about a human being who would do exercise with HCM. Okay, so we can't speak to you specifically, Richard, because we don't know all of your variables. This individual is saying, as an example patient, they exercise 30 minutes, 5 days a week, and the resting heart rate stays a bit high, 80 to 85. Yet I've read that tachycardia can worsen diastolic dysfunction. During my exercise, my rate goes up into the 90s, even the hundreds. I've read that I should keep my heart rate in the 60s or 70s. So what am I supposed to do here? What is a safe exercise routine for somebody with hypertrophic cardiomyopathy?
So,
They're both trying to figure out who's talking. Ethan, go first, then Marty.
so I think you have to always be a little bit cautious about, just using heart rate as a guide for exercise for the exact reasons that you're highlighting in this question. Resting heart rate can be really variable by individuals. And therefore I would really do it more based on perceived exertion. Heart exercise, high heart rates with exercise, though, do not worsen diastolic dysfunction. In fact, they actually might improve diastolic function. So definitely wouldn't avoid physical activity because of a theory that it might worsen diastolic function.
Marty, is exercise good in HCM?
Yeah, we've said that for a long, long time, that mild to moderate recreational level aerobic activity is, permissible and important for overall health, physical and mental, and HCM. And we've, the guidelines have supported that and continue to support that. So the answer is yes.
Okay. We kind of talked about Anonymous's question, what progress is being made in research and treatment for heart failures, both in general and specifically for HCM. I attended a meeting in Boston 2 weeks ago on this very topic, where there are many, many companies working on the problem of what's called HFpEF. Do you guys want to explain what HFpEF is and why there's some connections to HCM related to diastolic function? That was a mouthful.
Yeah, HFpEF refers to just what we call, that stands for, I should say, heart failure with what's called preserved ejection fraction. So when patients can develop heart failure with what looks to be a normal contraction or heart pump function, okay? And that's actually, more common form of heart failure than heart failure when there is a reduction or reduced pump function, okay? And so it's a very important cause of morbidity and mortality in the United States, HFpEF. And the connection with HCM is that non-obstructive HCM is a kind of form of HFpEF in a way, right? So you've got a patient that may have normal pump function, but have heart failure or limiting symptoms. And therefore it's kind of similar in a way, therefore, to, the broader HFpEF that you're talking about. And so, the idea then is that if some of the new treatments that are being applied to non-obstructive HCM, if those work at improving how patients feel by helping improve the relaxation and the filling of blood flow, and the overall performance of the heart, then that could be applied potentially to a broader patient population like HFpEF patients, non-HCM.
Staying kind of in this space, can mavacamten or myosin inhibitors be used to treat underlying diastolic dysfunction?
Currently under investigation, right now unknown, and hope we'll see what results come from the ongoing clinical trials for this.
Good answer. And at this point, this is my last question that I will pose to everybody, and then you'll have a minute to start typing your questions if you have anything in the private session you want to ask. Is there a mental health program tied to your clinic? And then I have an announcement after that.
No, there's no mental health program directly associated with the clinic. That's, something that we would like to move in the direction of having, as well as other potential kind of services that, kind of help overall improve the whole patient experience. And so we are kind of moving in that direction, kind of what a more integrated, delivery of healthcare, that it sort of embodies the whole body of the patient in a way, and mental health is certainly part of that, but we don't have that currently as it directly relates to the clinic. Of course, we could refer patients to those services, but they're not under the roof of the HCM center yet.
Well, I might have some help in that regard. HCMA is currently in talks with one of the online mental health service companies. And we are going to enter into an agreement if they answer a couple of questions, right? There's a couple of different services we've been vetting, and we've looked at one, and that one program, if we're able to onboard it, all members will get up to 30 days free therapy and a discount rate on the hourly rate beyond that. There are also potential opportunities for HCMA to partner with different centers to provide a gap to that mental health provider that can meet the patient on their phone or online. So we're working on figuring out a way to get better mental health care access, as well as provide training to those therapists giving that mental health service to help them understand the HCM life experience. So we've been talking to a couple of companies, and one or two of them were really not interested in learning anything. They just wanted to sell their service. And others were interested in learning about our community and having people vetted to treat and work with specifically our community. So while we were talking today, the email came back with a lot of really good answers. So we're one step closer to making that a reality, to provide better mental health care services for all. Yay.
That's great.
Okay, Facebook. It's been nice hanging out with you tonight. And we are going to say goodnight to you. Thank you for joining.